All right, we are going to get started. Welcome everyone to session 7 of the Washington Healthcare Facilities Initiative webinar series. My name is Joanne McGriff, and I'm the Associate Director of the CGSW, or the Center for Global Safe WASH at Emory University, as well as an Assistant Research Professor in the Department of Global Health at the Rollins School of Public Health. Today we will have a panel of 3 speakers who will be discussing the important role of cleaners in healthcare facilities. Again, I am joined by our members of our learning team, Ms. Lindsay Denny and Cassandra Savino. As you all may know, this series is part of an action-oriented learning platform that seeks to, as you see our motto, connect, share, and act. We connect the expertise and experience of our partners and colleagues to WASH and health community members who are interested in moving to action in WASH and healthcare facilities. We also provide a platform for the community of practice to share experiences, ideas, and best practices, as well as encourage individuals and groups to take action to implement sustainable interventions that improve WASH conditions in healthcare facilities. So to begin, I invite meeting attendees to start introducing yourselves by placing your name and organization in the chat box, as I continue to review some quick notes about the structure of the platform. And also, just as a note, when you write in the chat box, please make sure to select all attendees for your chat comments, just so that everyone in the room can see what you are writing. Okay, so moving on to the platform structure. As a reminder, each month we highlight a WASH and healthcare facilities subject matter expert in 25-minute presentations, followed by 30 minutes of facilitated discussion. As I mentioned, this month we're having 3 speakers who will present for a total of about 25 to 30 minutes, and then we'll move right on to discussion. For reference, please be reminded that you and your colleagues have access to webinar recordings, slides, learning materials, summaries, and action documents through our website, winhcfaction.org. And if you have questions or feedback, you can send us an email to winhcfaction@emory.edu. We are also on Twitter, so please consider following us on our Twitter handle at WNHCFaction. So now I'll pass on to Lindsay Denny, who will provide a few additional updates and reminders. And then after her announcements, I will introduce our speakers for today and move right into the learning session. Lindsay?
Great, thank you, Joanne, and good morning, good afternoon, everyone. Before we begin, I wanted to quickly touch on our guiding principles for this webinar series, as it helps us select both the subject matter experts and the subjects we discuss each month. So first, we believe WASH is a fundamental prerequisite for quality of care within a healthcare facility. Secondly, we believe there cannot be effective infection prevention and control without adequate WASH in healthcare facilities. Thirdly, sustainability should be built into every WASH and healthcare facilities project from the very beginning, no matter the project size. And finally, WASH and healthcare facilities is not just about addressing issues at individual facilities. Multiple systems, sectors, and stakeholders must work together to see sustainable improvements. So to highlight a bit of the background, many of you know SDG 3 and SDG 6, health and well-being and water and sanitation, both require WASH and healthcare facilities in order to be achieved. And back in March of 2018, the UN Secretary General Antonio Guterres used the launch of the Water Action Decade to make a call to action for WASH and healthcare facilities. Since that time, there has been a push for a resolution that will be discussed at the World Health Assembly on WASH and healthcare facilities in May. So lots of global action on this issue. We've done webinar sessions 1 through actually 6, looking at sessions on health system strengthening, assessment tools, implementation like healthcare facility, the clean clinics approach, and hand washing, research. So you can find all of that on our website. And that is leading us up to today. So a bit of background and news and updates. Monday was World Plumbing Day, and next Friday is World Water Day. So I hope you all are celebrating and getting the news out there about the importance of WASH in healthcare facilities. A couple of events that are currently underway or will be happening soon. The IRC All Systems Go WASH Symposium will be taking place this week in The Hague, and they'll be focusing on system strengthening. I hear there was a presentation today on health system strengthening as it relates to WASH and the lessons we could be learning from that. So excited to see presentations from there. In addition, on Thursday of next week, the U.S. State Department will be holding a World Water Day event on women in water, and there'll be a session on WASH in healthcare facilities and neonatal mortality. And I can, after this, put the link to sign up if you're in DC. Please come and join us at this event. Very exciting. And finally, next month, on April 3rd, WHO and UNICEF will be publishing 2 reports, the JMP report on WASH in healthcare facilities, as well as the Actions and Solutions document. So keep your eyes out for those. Quick notes on Zoom, feel free to use the chat box at any time to introduce yourself or make comments during presentations or during the discussion section. And then as well, during the discussion section, if you'd like to raise your hand, we can give you the opportunity to use your microphone to pose a question or make a comment. Please only use this feature if you have microphone capabilities on your computer or mobile device. And with that, I'll hand back to you, Joanne.
Great, thank you so much, Lindsay. So again, welcome to session 7, entitled The Role of Cleaners, the Neglected Frontline WASH Workers in Healthcare Facilities. We are pleased to have with us today Dr. Wendy Graham, who is Professor of Obstetric Epidemiology at the London School of Hygiene and Tropical Medicine, as well as Emeritus Professor at the University of Aberdeen. Dr. Graham has specialist interests in the prevention of healthcare-associated infections in mothers and newborns, with projects currently in Ethiopia, Gambia, Myanmar, and Tanzania. Dr. Graham is also Chief Scientific Advisor to a charitable trust focused on improving hygiene in maternity units, also known as the Soapbox Collaborative. We also have with us Ms. Emra Morrison, who is the Soapbox Collaborative Operations Manager, and she plays a multifaceted role within the organization, including project management, communications, and fostering partnership links between focal persons in the UK and overseas institutions. Emma is an experienced microbiologist supporting Soapbox, as well as external partners, to use and promote environmental microbiology to monitor and improve hygiene at the time of birth in healthcare facilities. We also have with us Ms. Claire Kilpatrick. She is currently a consultant to the Soapbox Collaborative. She has worked in global health for over 10 years, including with WHO on infection prevention, patient safety, and WASH in healthcare. This work includes campaigns, country missions, and the development of guidance and implementation strategies and tools, including those on hand hygiene, the core components for IPC or infection prevention and control, surgical site infection prevention, as well as WASH. Again, we are so very pleased to have all 3 speakers with us today. And without further delay, I will hand it over to Dr. Graham.
You all are still on mute, Wendy.
Thank you very much indeed to Emory University, and particularly to Lindsay, Joanne and Cassandra. We're delighted to be presenting here the work of Soapbox, this very small NGO which started in 2012 and focused, as already been mentioned, we focus on the reduction of healthcare-associated infections in mothers and babies in low-income countries. And although there are just the 3 of us presenting here today, I think, as the title will suggest, we are a collaborative, and I'm quite sure many of our collaborators will be on this line, and we look forward to their contributions in the discussion session. So the topic we've chosen sort of lies a little bit further, somewhat
Wendy,
close.
sorry, Wendy, could you share your screen?
Oh. Sorry. Just doing that just now.
Okay, we can see it. If you could just go to full screen, we will see it perfectly.
Perfect, thank you.
Apologies, and that is just by way of teasing you to really sit up and listen to what we're going to present, which is very much on the pathway between plumbing and WASH and IPC. So the focus here is on a very interesting piece of work that we've been evolving since 2012, and it's what you might call a voyage of discovery. And certainly when we started Soapbox in 2012, I don't think any of us imagined that what we were going to come across, which is this issue of the neglected role of cleaners. And so what we're going to talk about, we're using the word cleaners, but in some ways what we should be using is the word people who clean, and we're going to unpack that a little bit in our presentation. And so between the three of us, I'm going to sort of start describing the context in which cleaners play their role as frontline wash workers. Then I'm also going to talk about this voyage of discovery that we've been on. Emma then will speak about the response that Soapbox has launched related to the findings with our collaborators, and Claire will complete the loop, as it were, in terms of making the link between what we've done and the global architecture and opportunities to make a difference. So I think it's important that we come to this, and I think by way of the guiding principles of this series that have already been introduced. Those of us on this call, and largely the Soapbox Collaborative as well, we come at this as maternal and newborn health actors. So we're very familiar with the quality of care domain in this picture that you're seeing. We're familiar with this issue of the dimensions of quality of care. But early on in our work on healthcare-associated infections, it became clear that the domains of WASH, and clearly WASH exists outside of just healthcare facilities, but as soon as you move into healthcare facilities, this area of overlapping domains starts to become very important. And the reason why we emphasize this is there are real opportunities when one talks about WASH in healthcare facilities to, of course, locate it under the banner of quality of care, and in particular to look at these other elements, these subcomponents of infection prevention and control, quality improvement and patient safety. And I think it's wonderful to see over the last 5 or 6 years increasing the recognition that as we talk about issues related to WASH, we need to join up the connections or make sure we're having these connections with IPC and the broader umbrella of quality improvements. So how did we come to look at these issues of healthcare-associated infections in maternal and newborn units in low and middle-income countries? And I think the next slide, the third slide you hopefully will be seeing, shows the upward trajectory of institutional delivery, the percentages up the side and the time along the bottom, showing that out of 3/4 of the 140 million deliveries that occur each year, about 3/4 now are occurring in healthcare institutions, and that this proportion is increasing. In some parts of the world, we're pretty much almost universally having deliveries in healthcare institutions, not everywhere, but the proportion is increasing. And we are talking about big numbers, so this is a big global issue. Now, those of us coming from a maternal and newborn health background, many of us would believe that delivery in a respectful, good quality healthcare institution is a movement in the right direction. But that makes certain assumptions about the quality of care that women receive when they come into institutions. And the area of maternal and newborn healthcare is also an area that is prone also or susceptible, like many areas of healthcare, to what we call the iatrogenic effect, which is unintended adverse consequences. And one of the areas of adverse unintended consequences, besides things like over-intervention, which is not the subject of this talk, but certainly happens in the maternal and newborn area, but one of the other adverse risks is this in connection with healthcare-associated infections. It's related to, by definition, healthcare-associated infections, by definition, happen as a consequence and in relation to the delivery of healthcare. Again, a very, very big global issue affecting hundreds of millions of people every year in high and low middle income countries. What we know about healthcare-associated infections is the level of risk varies enormously between high and low middle income countries. As you can see from these statistics, 7 versus 15 patients out of 100 will acquire a healthcare-associated infection. In a high income country, the figure's 7, and more an estimate of 15 in low and middle income countries. But we have to be cautious because many countries lack routine surveillance of this burden of healthcare-associated infections, and therefore we lack reliable data. What we do know from very good quality studies is that surgical site infections are the most common healthcare-associated infection in low and middle income countries, and this can affect up to 2/3 of operated patients. which is 9 times higher than what you might see in low-income countries. And in the maternal and newborn area, caesarean section is the main surgical procedure that should be being done to save a woman and a baby's life. And with that, we see the surgical risk of caesarean section wound infection. The second slide that sort of sets out the landscape, we know that individuals that are high-risk patients, complicated patients, they carry a higher risk of infection. And very sadly, in the obstetric and newborn area, we do have complications that increase this risk innately. The neonatal population, as you can see from this slide, 3 to 20 times higher than in high-income countries is what we see the infection risk in neonatal populations in low-risk low and middle-income countries. And the last 2 points are really by way of a segue into the focus of this presentation, which is around who cleans and the cleaners. And that is that we know that in the transmission of bacteria to patients for these healthcare-associated infections happens typically by virtue of surfaces and hands, but also equipment and the general environment, air environment. But in that context, environmental hygiene, cleaning and disinfection of surfaces, together with, of course, improved hand hygiene, are critical to break the chain of transmission. So there is a knowledge base that exists around risks, and of course the role should be first to do no harm when we talk about healthcare, and healthcare-associated infections, of course, should be a target of considerable primary prevention, and in many ways are the main target of IPC, infection prevention and control. But when we move to lower middle-income country settings, we see an environment that it presents a number of different risks. The risks are slightly different between low, middle income on the left and high income, but there's an overlap. High use of antibiotics in low income countries, a limited use of class of antibiotics in middle income countries, a much higher range of class of antibiotics. This issue about crowding, a very common factor on the right hand side, this issue of family members acting as care attendants, this issue of floor patients, and this issue of few infection control staff and limited availability of hand washing facilities. And on top of that, we have this issue of how difficult it is to maintain hygiene and to ensure the environment is clean. The challenge to doing routine cleaning in these environments is sort of obvious when you look at these pictures. And in Soapbox, we do use a lot of imagery, and I will go on to use that because we feel these images speak 1,000 words. So in those, if you think about those environments, and we think about this, the next slide, which shows the 3 traditional routes of transmission, these traditional routes of transmission have been known about for quite a long while. It's a rather classic diagram that we're presenting here. But based on our experience, we feel that there are some modern methods of transmission that need to be given more attention, and in particular the role of surfaces, and in that the role of cleaning in terms of breaking the chain of transmission. Hands and surfaces, you'll see from that 2-way arrow, they can contaminate each other. But the 2 quotes we've included here at the bottom, the evidence about the importance of cleaning and disinfection are essential elements of IPC, but also importantly that visual cleanliness is a useful measure, but is not alone enough. Visual cleanliness is necessary, but not sufficient. And we bring this, as I said, this is a background to the work that we started to undertake. And when we started the work to look at the risks for healthcare-associated infections, together with our WASH partners and our IPC partners, the first thing we did was to sort of shine a light on the problem by virtue of conducting a number of needs assessments. And Soapbox developed this thing called the Wash and Clean Toolkit, which involves a number of different methods. It's a multi-method toolbox, which uses things like checklists and visual inspection, but also microbiology. And we carried out 7 needs assessments in 7 different countries, very, very different scenarios, but they all gave us a sense of an early discovery, and this is what started us on our journey. So the remainder of my part, before I pass on to Emma, is to show you with imagery the journey that we took. And the journey sort of started with a lot of visual work. We developed something called the walkthrough checklist, which involved looking at the environments in which mothers and babies were receiving care. We worked, as I said, in a variety of different settings, but typically these were maternity units with deliveries mostly above 50 deliveries a month. So reasonable volume of deliveries. And we started looking at beds and what women were being asked to do, not just to go to after they delivered. This is a bed that a woman would occupy after delivery. But we also looked at the beds in the delivery suite as well. And a common finding when we started to use, and I've just clicked to show a number of lovely purple bubbles that have suddenly appeared, and these are by way of proxies to show that we actually carried out surface microbiology, and these are Staph aureus high touch sites where we've cultured as what you might call hygiene failures, where the presence of Staph aureus was enough to indicate there was a hygiene failure. And what that showed us was this clustering of Staph aureus at the foot of the bed. So here, the top of the bed is the pillow on the right and the bottom of the bed. And this was true whether we were looking at labour ward beds or delivery beds or the beds that women go to before delivery or the beds they go to afterwards. So we started with in-depth research. We were working with very good social scientists to look to see what was happening. And what we saw were beds that were occupied by women who delivered, but also their visitors that were accompanying them. And we saw at the bottom of the bed were feet, many feet, mostly bare feet, but also babies as well, typically at the foot of the bed. And when you looked at the delivery bed, of course, that's also where the women's feet are, even if they're in stirrups, but also where the baby comes out, where there might be a perineal wound as well, and also where the midwife or the attendee might be placing their hands, even their gloved hands, to receive the baby. So the foot of the bed started to be critical. Why the feet became important, we then started to look at floors. And so we started to look at floors, and what we saw were the cleaners that started to, we started to watch cleaners that showed that the cleaners were using mops of various states of repair, as it were. The cleaners may well have been doing the correct figure of the S shape to try and move from dirty to clean. But it was quite clear that there were challenges. And the slide you're looking at now, I believe, is the one showing you a sink with a bucket, and just filling that bucket from a tap that's like that is not straightforward, because the bucket will not go under the tap, which means that another receptacle has to be used to fill the bucket. And if that receptacle is contaminated, so is the bucket. We also came across issues of the cleaning fluids bobbing problematic. Here, a whole load of stockpiled bleach, which if you test have been already over diluted. So this is what you might call counterfeit bleach. What we then also went on to look at in more detail were the mops. And here is a selection of mops. The mop on the left is basically a mop, an improvised mop being used in a health facility, which is essentially a t-shirt tied to the end of a stick. You might call that a garment factory mop, because typically the t-shirts are second-hand t-shirts from a garment factory. We won't go into the details of that, but those are mops that hold potential pathogens rather than shed them if you agitate them in water. And the other mop on the other side, which you can see with hands using it, and I've just brought in the lovely purple bubbles again to show that the mops were also sites where we were able to culture much Staph aureus. So clearly these mops were part of the mode of transmission. So women were working on contaminated floors that then getting onto beds and contaminating the beds and so on. But we were unable to find any modern textbook that talked very much about mops. I now often called Professor Mop to Bucket. Mops, there's a science of mops that needs much more investigation, but mops are critical. And what that took us on to look at were looking more generally at the cleaners, and you'll be seeing my last slide shows you work that we carried on to look at with the cleaners, with focus groups and interviews. These are cleaners in very different scenarios. what we found out were these were proud individuals who took a lot of pride in what they were doing. They felt typically very undervalued by their co-workers. They were often not referred to as part of the healthcare workforce, and that meant a number of things. Firstly, they were often at risk in terms of the PPE or the equipment they were given to protect themselves. And the second thing was that they were often untrained and had no concept really themselves about the risk to themselves, nor indeed their role in breaking the mode of transmission. And so this took us to this point of realizing there was a missed opportunity to work more closely with the cleaners and to try and break this or address this gap by working with our partners in terms of how we could help support the improved awareness and training of cleaners. And at that point, I will turn to my colleague Emma, who will take us on the next step of our journey.
Thanks, Wendy. As Wendy has highlighted, environmental cleanliness is one key part of a comprehensive infection prevention strategy. The Teach Clean package was developed to address the critical gap in training materials for those whose main responsibility it is to clean health facilities, and it's aimed particularly towards low and middle income countries. The package was originally developed for use in maternity units, however, it's readily applicable beyond this setting. The objectives of the Teach Clean package are to present the information and tools necessary to equip trainers to deliver comprehensive training and provide an overview of how materials can be adapted to the local context. The package also provides information and materials to support sustainable improvements. Following the release of the latest version in November 2018, we've shared the package with a diverse range of stakeholders, including ministries of health, IPC societies, and NGOs, and we're currently mapping the intended locations for rollout. Teach Clean lends itself to a cascade approach of training, often starting with a training institute and master trainers at a national or regional level, and who then both adapt the package to ensure consistency with local cleaning guidelines and training cleaning champions from within health facilities. The package takes into account the recommendations set out in the WHO guidelines on core components of IPC programmes, which state that IPC education and training should be delivered to all staff, including cleaners, using participatory training methods. The recommendation on teaching style refers to evidence that participatory methods are more effective for adult learners, and that's an approach that's very much at the heart of Teach Clean. Teach Clean is made up of 5 key documents, which I'll discuss very briefly now, and the package also includes a step-by-step guide to support implementation. Firstly, the instruction document provides users with all the information required to plan, adapt, implement, and evaluate training in facilities. It also includes a basic needs assessment tool that can be applied prior to training within facilities in order to identify gaps in knowledge, existing training, and resource availability, for example. The Clean Box document contains 7 core training modules on environmental hygiene and IPC, including an introduction to IPC, PPE, cleaning, and waste handling. Each module is presented in the same format and is referred to as a Clean Box, and each of these typically contains discussion questions, case studies, summaries of good practice, and photographs and posters to aid training. The latest version of the package now also contains 3 further supplementary training modules on how to train, supportive supervision, and integrating cleaning into broader quality improvement. And these have been developed to support the cleaning champions who would attend training of trainers' workshops. We would always advocate that cleaning procedure guidelines from participating facilities should be identified if available and used as examples in training where appropriate. However, in the absence of existing guidelines, or in cases where the guidelines available may not reflect best practice, Teach Clean does provide guidelines which can be used for training. Soapbox also developed illustrated cleaning procedure guidelines, and the example I've included here is the procedure for cleaning a blood spill. You can hopefully see that each procedure includes key moments for hand hygiene, the application of PPE, and also waste handling. And the real purpose of the illustrated guidelines is to provide an accessible reference manual for staff with limited levels of literacy skills. Following training, it's very important that cleaning staff are continually assessed to enable monitoring of standards, celebrate progress, and highlight areas in need of improvement and further training. During the Training of Trainers workshop, the theory and methods of supportive supervision are discussed, and trainees learn how to apply competency-based assessments. The package also provides specific guidance on conducting the assessments, along with a referral procedure, which I've shown here just to give an example. And this outlines what to do in the event that an individual passes or indeed requires to be reassessed following additional support or training. Templates are also provided for assessment checklists and records, and these can all be adapted to local practice. An Advocacy and Communications resource pack is also available to provide key stakeholders with the information necessary to effectively share Teach Clean and advocate for improving training provision for frontline WASH workers in healthcare facilities. The package contains helpful FAQs, slides, videos, and other materials that will provide useful information on the package, along with advocacy messages that will support activities calling for cleaner, safer health facilities. Now that I've given you just a very brief summary of the contents of the package, I'd like to share with you a snapshot of the pilot study, which was conducted in the Gambia in 2016 in collaboration with our partners Horizons Trust and the Ministry of Health. Prior to the pilot, a needs assessment was conducted which noted a number of suboptimal IPC practices within maternity facilities. During a 4-day training workshop, 9 supervisors were trained, and over the next 6 to 9 months, they in turn trained 50 cleaners or cleaning staff from the 4 participating maternity facilities. Following training, direct improvements to hygiene and IPC practices were observed across the facilities, and I think it's important to note here that these improvements were observed even within the constraints of resource limitations. Pre- and post-training assessments recorded enhanced IPC knowledge and practice of both the trainers and the trained cleaning staff. And in each pilot facility, Teach Clean has become fully incorporated into a broader IPC programme, which is supported by Horizons, and this has resulted in sustained improvements to environmental cleanliness over the last 3 years. Before I hand over to Claire, I'd love to share with you a short film that we've developed with our partners Horizons. The film gives an overview of the pilot in 2016 and the impact training has had within facilities, and hopefully it plays okay just now.
Knowledge, attitudes and practice of care providers and support workers to provide safer women-centred maternity care, to have stronger advocacy for infection prevention and control at all levels, and to reduce preventable infections at birth. We ran a 3-day workshop facilitated by Soapbox, the Ministry of Health and Horizons. There were 6 participating health facilities with multidisciplinary representation, and the aim of the workshop was to establish a phased programme to reduce healthcare associated infections in childhood. Under the workshop, we carried out visits to 6 of the facilities to help to support the changes. This is where I need to accomplish Soapbox and regulated by
Unfortunately, Emma, we're having a hard time hearing the video sound.
Oh, okay. No worries. Hopefully we can maybe share that again after the webinar. Would that be possible?
Absolutely. We'll make the link available to the participants.
Okay, thank you.
We put the link in the chat box if you have it available even now.
Okay, great. In that case, I think we'll move on to Claire, if that's okay.
That's perfect.
Thank you, everyone. It's my pleasure to now try to just summarise some of the key messages that we've heard even since Lindsay introduced this webinar series. So I just focus again on the global profile that WASH in healthcare facilities has been receiving since 2015, but importantly since last year, and the fact that we want to move from promoting awareness of the issue and the burden that lack of WASH in healthcare facilities causes to patients and health workers to action. So as Lindsay mentioned at the beginning, we're going to be seeing much more action and a year of activities to start off looking at how people, many partners, including Soapbox Collaborative, are actually aiming to achieve the standards in healthcare. And it's important to note as well that this week in Ethiopia and Addis Ababa, there is a quality of care network currently underway, which happens every year. And as many of you may have noticed from social media, there's numerous messages being posted by our WHO Afro colleagues and others about WASH in healthcare facilities as part of that quality of care. So that brings us back a little bit to where Wendy started talking about the focus for the Soapbox Collaborative to ensure that there could be a valuable addition to this agenda by presenting a unique participatory training package, as Emma has described, in order to support all of the action that is happening and that will become even more important if we're to advance this agenda. On the next slide, you'll see that I just summarise again here some of the key points that you will all know, but that actually Wendy outlined some of these, but really important to just remember the burden of healthcare associated infection that affects patients and health workers every year in all countries. But of course, these data vary for between high and low and middle income countries. And that's the focus. That is what Wendy has described, how important those vulnerable people in maternal and childcare in particular, but across health facilities in low and middle income countries are. And just adding to what we already know, but knowing how much we have to do to address this issue. And the challenges of addressing HAI include, as we've mentioned, some non-existent infection prevention and control programs and guidelines. But that in itself is a massive aspect of preventing these infections and addressing this burden. But combining that with inadequate water supply, poor sanitation, and the weak hygiene infrastructure, as outlined in the environmental hygiene aspect by Wendy, we can understand just what a journey we have to go on to make sure that we can improve the lives of everyone. In the next slide, I just summarise again what we are calling the opportunities for Teach Clean on a global scale. So Emma mentioned the fact that the WHO Infection Prevention Control core components were launched. This was in 2016. And the specific systematic review, the evidence review, found that there were critical facts for education and training, as well as many other aspects of IPC programs, including the infrastructure for hospitals to prevent infections. But just thinking about the education and training evidence, we're clear that there's a strong recommendation for facility level where that education should be in place for all health workers, and that these strategies should be participatory and include bedside and simulation training to help reduce that burden of HAI, as well as antimicrobial resistance. And I think that's really critical, that we're really looking at not just, are we doing some training? We're talking about how effective that training is. And the Teach Clean package provides that opportunity for that particular targeted healthcare worker group. It's also important to note, as Lindsay already mentioned, the potential that we have going forward based on a number of globally available tools and documents, some which have still to come this year, and they include a WHO implementation manual supporting prevention of carbapenemase-resistant organism infections, which contains a whole chapter on cleaning, where Teach Clean, the package, is outlined as an example of a package that you can use to support your actions. And as Lindsay mentioned, a WHO UNICEF document on washing healthcare facilities, which outlines practical steps to help achieve that global vision that was outlined by the UN Secretary General about addressing the issue. Within that document, Teach Clean package case study is featured, summarising some of the information we've given to you today about how it was established and how it's already being used in many countries. Additionally, colleagues from the Centre for Disease Control and the Infection Control African Network are releasing very soon a best practices document about cleaning in healthcare facilities. This is really critical because there's been a gap in the global documentation in this regard for some time, and it's been our pleasure to all work together with the leaders of CDC and ICANN on this document. And there's a link on the icannetwork.co.za web pages where it outlines that this document, which is a comprehensive manual outlining best practices, will be coming very soon. The purpose of the best practices are to improve and standardise implementation of environmental cleaning procedures in patient care areas in all health facilities, but it has a particular focus on limited resource settings. So the official launch is planned for September this year, but encouraging everyone to keep a check on the ICANN web pages to look out for this document. And again, that links very nicely with the opportunity that Teach Clean provides in order to help people achieve all of the things contained within these global standards. On the next slide, I particularly highlight to you the WHO Infection Prevention Control Assessment Framework at the facility level. And one of those indicators, there are indicators around the built environment, there are also indicators for education and training. And it clearly states how frequently do cleaners and other personnel directly involved in patient care receive their training. There's currently a global survey underway by WHO to ask all health facilities to use this IPCAF tool. When asked that question, how will health facilities demonstrate that they're achieving that indicator? Well, the Teach Clean package provides an opportunity to very substantially do that. And we hope in a joined up way, all of these documents will be referred to, all of these tools will be used, and Teach Clean will become an integral part of the global agenda around WASH and IPC. Next slide. And not to forget the very important AMR agenda and how much this all links together. If we take just one example, of course, the global agenda and AMR is a massive agenda, but if we're looking at where we can consider assessing environmental hygiene for WASH and think about the use again of the Teach Clean package, the tripartite AMR country self-assessment does have a very, very specific objective around this. And again, we would encourage everyone to be joining up all of this work, all of these agendas together and finding solutions together. And Teach Clean is one of those solutions. Next slide. I want to close on behalf of my colleagues by saying that I'm sure we will all have been engaged and in fact moved by the short stories told here today around why the Teach Clean package was created, why it is so important, and the research around that led by Wendy still goes on. But the evidence is there. The evidence from the work that the Soapbox Collaborative has done has helped. But the evidence from all of the global agenda around WASH, IPC and AMR exists. So we should not be waiting any longer. We should be taking on board all of the tools that we have available to us and being as enthusiastic as the people, for example, here in the Gambia, who have embraced the Teach Clean package as part of their agenda. And this is a great quote by the trainer who was very much instrumental in implementing the package with all of those in the health facilities. And you can read for yourself, but the fact that it was so helpful and it made them happy because they were surprised that those cleaners, those people who clean, that are so often undervalued, actually have so many talents to offer the health facility. to help advance and protect health workers and patients. And this trainer had underestimated them, but each time standing in front of them, the ideas they brought out and their understanding and in fact their willingness to learn was very fast, and it made everyone very happy. So we have a global challenge, but we have some solutions and we have some evidence that we really can make a difference through using something like the Teach Clean package. And with that, I will stop now and we look forward to the questions.
Great, thank you so much, Claire. And that is an excellent point to end on in terms of us having solutions, that there is something that we can do. So again, thank you for your presentation, to Wendy Graham from the London School of Hygiene and Tropical Medicine, as well as Emma Morrison, and finally Claire Kilpatrick from the Soapbox Collaborative. As Claire just mentioned, we are moving now to the discussion session of our webinar. I will open up the floor for questions, so if you have not already, please start typing your questions into the chat box or use your raise your hand function on the Zoom menu. I understand that we had a few difficulties in the beginning with the chat box function where you could not select all panelists and all attendees, but now you can. So please be sure as you type in your questions, again, that you select all panelists and all attendees so that everyone can see what you're writing. I believe we also have a little note on that in the chat box from Lindsay. And remember also with the raise your hand function, only we can unmute you. So just please keep that hand raised if you want to say something so that we can see you. If we don't get to your question today, remember that we'll do our best to work with Wendy, Emma, and Claire to respond to as many questions as possible that we will post on our website after the webinar. We'll also be posting all of the other resources and links that were mentioned in the webinar on the website and in our action documents that get posted. So let me start off with a question as the attendees are typing in theirs. Again, Emma, thank you so much. You went through the Teach Clean package so very well, and it was so very good to hear that you have some data or information that shows the sustainability of the behavior change that you saw with the cleaners. Do you have any tips that you can share with us regarding what you think made that happen? There's some mixed feedback or feeling about training of trainer type of models. How well did you think that worked, and what are some tips that you could provide to tell us why you saw that change in behavior sustain for so long?
Great, well, thank you for the question, and I'm so sorry the video didn't work out because it was a good opportunity to meet some of the trainers and hear their experiences. But the training of trainers module worked very well in the Gambia because we had a lot of buy-in from the local NGO on the ground and also the Ministry of Health. So I can give you a bit of an update now in terms of what's happening in the Gambia, in that the Ministry of Health have developed a programme to train national IPC trainers. I believe there's currently 8 members of the Ministry of Health staff trained, and all of these trainers now train facility-based IPC trainers, which I think are numbering around 28, and they're very much leading the national conversation on IPC. So we have this big buy-in. And Horizons, the local charity there, are now finding that the IPC agenda is being led by the facilities themselves, and they're identifying the major gaps in terms of knowledge, and they're putting the training in place to address that. In terms of data of improvement, what we're seeing is that pre and post training, we're getting around a significant 25 to 30% increase in knowledge and competency of the health workers, including the orderlies. And because a lot of the staff there have never had any training opportunities before, especially in IPC measures. And in the focus facilities we're working on in the Gambia, they're conducting quarterly IPC assessments, and they have an increasing percentage score currently, and it's currently at about, I think, 75% compliance at each facility. So we're seeing strong signs of improvement there. I think hopefully that answers your question a little bit.
Great, thank you so much. And it's so very good to hear the many layers that are operating together in order to make this work sustainable. So again, thank you for that explanation. That's really helpful. We have a hand raised from Jacob Nkwangote from the Cameroon Baptist Convention as well as I can. Jacob, can you hear me? Jacob? You're still on mute. Jacob, can you hear it? Okay, while we try to get Jacob back, what I'll do is move on to one of the text box questions from Steve and Sarah from Save the Children. The question was, are there resources we can refer to for effective MOP use / care practices, which really brings in the point that Wendy was making. Does anyone want to respond to that?
Thank you very much, Stephen. Yes, Professor Mott would attempt to reply. I mean, I think this is an area that does, not surprisingly, I'm going to say does need some more work. But in the guidelines, in the Teach Clean package, we have drawn on what national guidelines in a variety of different countries use. I'll give you an example of where it's really important to look at the local context as well. But then there are a set of procedures, both in terms of cleaning the mop, but in particular storing mops. The type of mop and the storage of the mop is absolutely critical, as well as, of course, the cleaning receptacle that's being used, the bucket. But in terms of storing mops, there's a bit of a sort of area that does need some further investigation. So the standard international sort of advice is that mops should be stored upside down with the head in the air. And the main reason for that is that it allows the head, which is the wettest part, to dry quickly, be aerated, and therefore, you know, particularly to be stored in sunlight in particular. That's the recommended practice. However, from some of our work in Tanzania, and that's another area where there is ongoing work with Teach Clean right now. Interestingly, we're working there with the wonderful Muhimbili University Training Institute. And they have been the training institute that's done the training across the 3 major hospitals. And one of the things that happened was a distinction between, or a difference between the national guideline, which suggested that the mop should be hung downwards, and what we had put in Teach Clean. And the interesting thing when we probed into this was the view nationally in Tanzania is the mop head should be held down because the handles were wooden and they would tend to rot as they were remaining wet for much longer. Whereas in fact, when we look at the guidance that comes for storing the mops with the head in the air, that typically is in situations where the handle is plastic, and therefore you don't need to worry about the rotting wood. And so this issue about understanding the local context, as it turns out, you don't want a rotten handle if you're using a wooden handle. So there are good local circumstances for trying to dry the mop partly upside down and partly upside down and partly head down. And that's an example of we still need some scientific work, and also need to recognise that the materials like a plastic handle versus a wooden handle may mean that some of the practices we recommend need to vary. So thank you for and anybody who'd like to get involved in the art and the science of mops, do send me an email. Thank you.
Great. Thank you so much, Wendy. Moving quickly, we do have a few other questions we want to cover. We have Dan Jones from WaterAid, who's thanking you and telling you that he learned quite a lot in this session, but has a comment that you highlighted that part of the issue is that cleaners are undervalued and seen as separate from the healthcare staff. While training or capacity building is part of the solution, do you have any examples of concerted efforts to shift the issues of power dynamics and hierarchy so that those who are clean or cleaners are more valued, respected, and empowered? Interesting question. Anyone?
Yes, I'm not in the same place as Claire. Claire, do you want to start off, and I'll follow on, or happy to do a dual act here?
Yeah, no, Wendy, do carry on. Yep, I think it's important for you to share the learning from Teach Clean in this regard.
Okay, so I think the best example I think of this is the work with BRAC in Bangladesh. Many of you will know BRAC, and BRAC has a very strong empowerment sort of principles around its work. And therefore, when we started working with them and Teach Clean and we did the initial needs assessment, it was quite clear that they recognised that undervaluing of cleaners is something that needed to change. And it starts with the management. it starts with recognition at the highest level within the facility that these are individuals who can make a difference, but you have to work at it. And we had many examples of focus group discussions that started off being separately with cleaners versus the professional healthcare workers, but then progressed into group discussions that had everybody together. And slowly, and I think you'll see from that quote, Dan, from the Gambia, slowly our recognition was that typically it was the healthcare professionals who didn't realise the role, and once they were became more aware of this, the willingness to encompass these individuals sort of happened naturally, but you do need management buy-in. Having said that, I think it's also important to recognise that there are often cultural factors that are at play, and I think sometimes we do need to acknowledge, I mean, we're working in the maternity unit, and some of you on this call will know that in some parts of the world, childbirth is seen as a polluting activity, and therefore dealing with issues of women's blood and the pollution that surrounds childbirth means that with that pollution goes a sort of a poor status or poor, almost stigmatizing of those individuals who do the cleaning up after women have given birth. So again, I just need to appeal to this issue of culturally sensitive, culturally aware. You need to understand the cleaning context and also the context of childbirth, so you can understand the barriers to empowerment of these individuals. It is not always just knowledge, as Dan acknowledges, but it is also understanding this cultural context of childbirth. So you do need good social science and good awareness of that context of birth to really work out the best opportunities to shift that attitude towards cleaners and cleaning.
Great, thank you, Wendy. Anyone else want to make any more comments? We have one additional question. Okay, so we have one last question we'll take, or actually comment from Steve Werner. He says, can I assume that cleaners aren't paid very well? And how does that affect turnover? And do healthcare facilities then get overwhelmed trying to retrain cleaners on why and how to do proper cleaning? So great question about turnover.
Hi, really great question, and I can provide a little bit of example about that in the Gambia. Yes, in general, poor paying conditions are a feature, and there certainly can be a turnover of staff. I think the joy of having an IPC trainer within the facility means they can conduct the fresher training or the peach training. In the 5 facilities in the Gambia, I know that they actually repeat the training once a month. Now that might only be one of the 7 modules. They might focus on waste handling that month, but it means there's a regular and sort of repeated opportunity to make sure that your staff are being engaged in a training that wasn't previously there.
Yeah, and if I can just add for that, I mean, I think it goes back to the earlier point, Stephen, and thank you very much for your question. I mean, again, people have often asked me, can you deal with cleaning as a single intervention? And one of my favourite phrases in maternal and newborn health is there is no magic bullet, and cleaners certainly aren't them. You need system-wide improvements, you need to locate this in a system-wide strengthening. What I mean by that is that, retraining is part of continuous quality improvements. And the turnover of staff is true of healthcare professionals as well as it is of cleaners. And so you want this to be embedded in mechanisms that continuously recognise the need for updating and for retraining. And this is no different. So I strongly appeal to not trying to have the sort of cleaning retraining as separate from what routinely needs to happen. If you believe in continuous quality improvement and continuous education, which is what we need, constantly you need to remind it. And the cleaners are no different. We all resume to poor practices if we're not reminded. So it should join that. In terms of the pay, it's very interesting. And yes, generally speaking, as unrecognised healthcare workers, their pay is typically very low. That's not the same as not having power. And in fact, we came across one situation in part of India where we're working, where there was a scenario of the doctors going on strike, and basically the hospital carried on. But when the cleaners went on strike, everything ground to a halt. So pay is important, but it's not the only thing that affects self-efficacy. And for me, it's about acknowledging the role they can play and the value of that role in infection prevention. The other thing just to mention is that pay will vary according to a number of different factors, not the least of which in many situations cleaning is outsourced to private companies. That doesn't necessarily mean the individual is paid more, but from the health service point of view, they may the facility itself may be paying more. So it goes back to one of the things I said at the beginning. You really need to understand the cleaning landscape in a facility and in the context in which you're trying to work. Who cleans, what they do, how they get paid, and this issue of the context of birth and power in a facility that enables you to bring about sustainable change.
And just really briefly, this is Lindsay Denny here. Just really briefly, in Cambodia, the work that we did, we made the assumption with cleaners that they were not at the facility very long, and actually the majority of cleaners we trained had been at the facility for 5 to 10 years, which was actually longer than most of the clinical staff that we worked with who rotated more quickly. So I think that the assumption that we have that cleaners are short-term and constantly turnover isn't necessarily the case.
I was just going to add one last thing again, just to put it in the context of much of what Wendy said, but all the other things going on. There's a massive health workforce agenda, being addressed. We can't do this again in isolation. We can't put it all on, as Wendy has said, if we just focus on improving cleaning, then we will fix massive issues around health systems and health workforce. But we have an opportunity to show how many of these stories, including what Lindsay's just said and Wendy said, how they can play a role in that quality improvement and that whole agenda. But I think very importantly, we have this opportunity again to put it within the context of infection prevention and control. And if you look at those 8 core components, then we really can see that the sort of environmental hygiene, cleaning, education runs through all of those. And as we're getting more and more attention at national level and health facility around that part of quality improvement and IPC at facility level, we really can see how fixing all elements that are evidence-based will support this. So I think, again, as Wendy said, nothing's ever in isolation. We have to take this multimodal approach. But again, to end positively, we have these many opportunities with a number of other global agendas that we can make sure we work together on.
Great, thank you so much. We have come actually to the end of our time on this webinar. We want to again extend our sincere thanks to Dr. Wendy Graham from the London School of Hygiene and Tropical Medicine, and both Emma Morrison and Claire Kilpatrick from the Soapbox Collaborative for such great presentations today and responding to our questions. We do realize that there are several text questions that started coming in. Unfortunately, we cannot cover them on the webinar session right now, but we will work with Wendy, Claire, and Emma to respond to these questions and then post them on our website and make them available to you on our listserv. I will now pass it over to Cassandra, who will wrap up for us.
Thank you again, everyone, for participating in this month's webinar, and thank you again to Dr. Wendy Graham, Claire Kilpatrick, and Emma Morrison for your wonderful presentation. We will leave the chat box open for a few more minutes, so please feel free to post any additional questions or comments you may have. Remember that you can submit future webinar topics in the chat box or by emailing w&hcfaction@emory.edu. Today's recording, slides, and a summary document will be available within the next 2 weeks at w&hcfaction.org. We are looking forward to next month's webinar, which will focus on national action in Tanzania with presenters from UNICEF Tanzania. Please stay tuned for details on the date and time. Thank you so much again for your participation today.
Thank you all. Have a great rest of your day.
Thanks, everyone.
And from Soapbox, thank you very much for inviting us, and to all of those who've given us questions. And please do keep in touch with us. Thank you very much.